Hi folks, welcome to this short series of 3 lectures looking at some common drugs used in the emergency department for neurological conditions. So we're going to divide this into 3 parts. The first part will look at drugs used in status epilepticus. The second will look at antipsychotic medication. And the third, antidepressants. And for each of these groups, we are going to look at the clinical pharmacology of the drug, the relevant pharmacokinetics, and as usual, we're going to use some clinical scenarios to help us understand what we need to know about these drugs. So, a 56-year-old man presents to the emergency department in status epilepticus, and we're going to think about which drugs we might administer acutely, how they work, and what are their contraindications and side effects. Now, for this short lecture, I'm going to just focus on the drugs used in status epilepticus. However, for your part 1, and actually for your clinical practice, you need to know a little bit about the pharmacology of drugs used for long-term control of epileptics, as these patients may present with side effects of their drugs or may present with other conditions, and you might need to understand the pharmacology of the drugs that they're on before you prescribe other medication to them. That is not the focus of this lecture, but just to remind you that you need to do that. So I just want you to pause here and think about which drugs you're going to use and in what order. When you've thought that through, then you can start the video again and look at what we've got. So the first group are the benzodiazepines, and the ones that we commonly use are lorazepam, diazepam, and midazolam. Second line, we use phenytoin, and in other countries, fosphenytoin, which is a prodrug of phenytoin, can be used as well. Paraldehyde is a fairly old-fashioned drug, but it is a useful third-line drug if phenytoin is not effective. And then the barbiturates, both phenobarbital and sodium thiopentone, to be used as part of rapid sequence intubation in the patient with refractory status epilepticus. We need to consider the possible use of propofol as well in these patients who have not responded to first and second line treatments. So let's think about the benzodiazepines. For each of the drugs, I want you to just think through the pharmacokinetics, the pharmacodynamics, mechanism of action, indications and contraindications, and side effects of these drugs. So what is the mechanism of action of benzodiazepines? Again, at each point you can just pause the video and see if you can work this out yourself. Well, benzodiazepines are GABA agonists, and GABA is one of the main inhibitory neurotransmitters in the brain, and it has quite a profound effect on the overall brain activity and in certain general systems such as the RAS. The use of this drug and the stimulation of GABA causes sedation and respiratory and cardiovascular depression. And the drug is known to be an amnesic, or these drugs are known to be amnesics, though they are not analgesics. The side effects can be worked out. They cause sedation and respiratory and cardiovascular depression, and these effects are potentiated by, and these drugs potentiate the effects of opiates. How can you give benzodiazepines? Well, they can be given intravenously, by the buccal route, the intranasal route, or rectally. The second drug is phenytoin. Again, you can pause the video and see if you can work out the mechanism of action of this drug, its indications and contraindications, its side effects, and its route of administration. So it's a sodium channel blocker which stops the repetitive firing of neurons that are typical of patients in status epilepticus, but it also affects other conducting tissues, in particular other CNS tissues and the conducting system of the heart. So its acute side effects can be worked out from this. It causes CNS depression. It can also cause bradyarrhythmias and hypotension. When used long term, phenytoin can have certain chronic side effects as well, such as folate deficiency, ataxia, gingival hyperplasia, hepatitis, and a lupus-like hypersensitivity. Fosphenytoin is a prodrug of phenytoin. It's easier to administer. It needs to be given by slow IV injection, but actually can be given about 3 times as fast as phenytoin, and when given, it is metabolized in the liver and red blood cells and peripheral tissues to phenytoin, which is then the active drug. The thing is, when it's injected, therefore, before it reaches its site of action, it is mostly in the prodrug state, and therefore systemic side effects are reduced. Its onset of action is 15 to 30 minutes, so similar to phenytoin, maybe a little bit shorter, and it has a better side effect profile. It has similar side effects to phenytoin, but less. And then we move on to the barbiturates. So these are GABA receptor agonists, similar to benzodiazepines. They increase the effect and duration of GABA at sites of action. As with the benzodiazepines, we can therefore work out their acute side effects, respiratory depression and hypotension, and these effects are synergistic with benzodiazepines. So when you're treating somebody with status epilepticus, you have to be careful if they're already on a barbiturate when giving them benzodiazepines, or if you've already given them a benzodiazepine when giving them barbiturates. Sodium thiopentone is an ultra-short acting barbiturate, and it can cause profound respiratory and cardiovascular depression. It is a general anesthetic. In light of this, we have to remember that people given an anesthetic dose of sodium thiopentone will lose their airway reflexes and are at risk of aspiration. Bear in mind it also accumulates in fatty tissues. It stops working because of redistribution, so the drug is still in the body but stored in the fatty tissues, and therefore in the long term these patients can have long-term CNS effects from acute doses of phenytoin. They may experience prolonged drowsiness after. This is particularly so after an infusion, and sometimes when used in prolonged infusions, patients can take quite a while to wake up afterwards. So we've given drugs like benzodiazepines, phenytoin, phenobarbital. The patient is still fitting. What is the role of rapid sequence intubation and paralysis? Well, the aim of this is to control the somatic seizure activity and also allow ourselves to be more aggressive in controlling cerebral seizure activity without fear of respiratory depression, because the patient is now intubated and ventilated. So what we do is we sedate the patient with a potent anti-epileptic drug such as thiopentone, propofol, and paralyze them so they can be intubated. Then the question is, what do we do after that? Well, the balance is between continuing the paralysis and sedation, or allowing the paralysis to wear out and continue the sedation and anti-epileptic drugs. And really, we need to balance the need to monitor seizures, which can only, unless you have EEG, This can only be done by allowing the paralysis to wear off so we can better notice when the patient is seizing. But also then we have to balance that against the patient's safety and the potential for loss of the airway. A patient who is not paralyzed who starts to seize can very well cough up their tube, and then you're left with a patient with an unprotected airway. What we tend to do is that in the emergency department we use paralysis and sedation. If we know that the patient is soon to be moved, say to the ICU, we continue the paralysis. Once the patient is in a safe, stable environment and unlikely to be moved, at that point we can allow the paralysis to wear off. How would we monitor patients who are sedated and paralyzed or heavily sedated? How do we monitor them for seizure activity? Well, the gold standard is an EEG, but in absence of that, some signs, subtle signs of seizure activity would include sympathetic lability, variations, sudden erratic variations in blood pressure, heart rate, pupillary hippus, which is alternating constriction and dilatation of the pupil, and subtle motor signs such as ocular deviation or mild focal signs, twitching of the face, arm, or lip smacking, or the repetitive movements. So we have to be monitoring these patients very carefully once we have decided to paralyze them and ventilate them. And what we're looking for is signs of cerebral seizure activity. Because remember, if we stop the somatic seizure activity but allow the cerebral seizure activity to continue, the brain is still going to suffer the ill consequences of prolonged seizure activity. We're also just going to finally look a little bit on sodium valproate. It blocks sodium channels and enhances the production of GABA. Acutely, it can cause encephalopathy and hyperalbuminemia, particularly in patients with known hepatic abnormalities or pancreatitis. When given chronically, it can cause teratogenesis, so it's conjugated pregnancy, and it can also cause anxiety and psychomotor agitation. Patients on sodium valproate have developed dermatological problems such as alopecia and discoid lupus, and even hematological problems, thrombocytopenia, anemia, and pancytopenia. It is worth remembering that other anti-epileptic drugs such as phenytoin can also cause bone marrow aplasia and pancytopenia, as well as thrombocytopenia. These are a few novel anti-epileptic drugs. You might want to just pause the video and have a look at what they are and how they work. Some of them are not new, such as ketamine, but are only more recently been used to treat status epilepticus. So if you have any questions, you can raise them with me in class. As I said, this is the first of 3 short lectures. We're going to have one on antipsychotics and one on antidepressants as well. Thank you.